So first, good afternoon all. I'm going to start showing a case and you all are going to recognize what the case is, and accordingly we'll move on to our class. Okay. So this is a patient who was 31 years old. She was a female and she came with the chief complaint of an ulcer and pain in the right inner cheek region since 3 months. Okay. So initially the ulcer was reddish in color, very small in size, about the size of a peanut, which rapidly increased to reach the present size in a matter of 3 months. It is associated with pain since 3 months, which is severe in intensity, continuous, aggravates on chewing food, and also while speaking. She also gives a history of repeated accidental cheek biting in the same region since 6 months. And she has been having difficulty in opening her mouth fully since past 3 weeks. Okay. Now she had visited a general dentist for the same 2 months ago and was prescribed topical application of a anesthetic gel, that is Dolo gel. And she also underwent the extraction of upper and lower right wisdom teeth. Okay. Topical application of the gel did not help her, and subsequently she developed difficulty in mouth opening since past 3 weeks. Now she visited the same dentist 2 days ago and she was referred to my postgraduate institute. Okay? And she has no history of fever or weight loss and no history of any recent hospitalization. And apart from that, no other relevant significant family or medical history. Oral hygiene habits are good, no other habits. And on general clinical examination, no abnormality was found. And even her vitals were within the normal range. Now, on the examination of head and neck, on extraoral examination, nothing of significance was noted. And one thing which was noted was her lymph node was palpable, level 1B lymph node, that is your submandibular lymph node. It was palpable, it was fixed, stony hard in consistency, it was non-tender. Okay, so all these points are supposed to be picked up by you when you examine the case. Okay. Apart from that, no abnormality was detected. Now, when we moved on to intraoral examination, there was an ulceroproliferative lesion, okay, in the right retromolar area. Okay, and another thing which was noted was there was limited mouth opening, and the ulcer measured about 2.5 to 2 into 2 centimeter. It was irregular in shape. Borders appeared everted, okay, and surrounding area appears normal. On hard tissue examination, there was nothing of any abnormality that was detected. On palpation, again, all these inspectory findings were confirmed and it was severely tender. Okay? And everted margins were noted. And when you palpated, there was mild induration, that is hardness, was present at the base of the ulcer. And there was no bleeding or pus discharge on palpation. On hard tissue examination, apart from the missing 1/8 and 4/8, no other abnormality was found. Okay. And the other soft tissue examination also, nothing abnormal was found. Okay. Periodontal status also was fine. So basically, to summarize, you have a patient who has had some kind of ulcer and pain in the right inner cheek region since 3 months, and she had got her tooth extracted because she had a history of cheek biting. And despite the extraction, the pain did not subside and it has become worse. Okay? And since past 3 weeks, she's having severe pain. Okay, so based on all these, can anybody give me a provisional diagnosis? Anyone? Can anyone think of a provisional diagnosis? What could this be? Anyone? Okay, you all got enough clues. There was an ulceroproliferative growth, lymph nodes were stony hard. So what could this be? Take a guess, anyone, otherwise I'll randomly start calling out names. No one knows? Okay, Atul, what could this be?
Ma'am, Arila.
Okay, I'm not wasting more time. Okay, it is pretty obvious. There is an ulceroproliferative lesion. Okay, and the base is indurated. Lymph nodes are palpable. It is stony hard and it is fixed. All these are clear-cut indications of a malignancy or a malignant ulcer. Okay, so this is something which you have to know. Okay, these are basics what you study in your case history or in your examination exercises. All these are basic things which you will learn. Okay, so therefore your provisional diagnosis is a malignant ulcer of the right buccal mucosa. Your differential diagnosis can be chronic traumatic ulcer or ulcer due to a deep fungal infection. Now, investigations were carried out for this particular patient. Hematological investigations were all within the normal range. And in the orthopantomogram, we could not appreciate any other bone changes apart from slight, slight areas of radiolucencies here and there. Okay. Now, what happened is when we took advanced imaging, CT imaging, we were able to see that there was a widespread area of involvement. Okay. The whole of the ramus, the base of the skull, pterygoid plates, all this was involved. Okay, so something which started off as a cheek biting due to malposed or malpositioned third molars. Okay, due to repeated cheek biting, she developed something as drastic as some kind of a malignancy, which involved all her the area which was just adjacent to that particular buccal mucosa, that is your ascending ramus, your base of skull, pterygoid plate, all that area was involved. Okay? And even the lymph nodes were involved. And incisional biopsy was done from the right buccal mucosa and the tissue was sent for histopathological examination. And what we got was, there was invasion of islands of dysplastic epithelium, and all these features, there were multiple keratin pearl formation, vascular connective tissue stroma, all these features were suggestive of a well-differentiated squamous cell carcinoma. So therefore, our final diagnosis for this particular patient or lesion is well-differentiated squamous cell carcinoma of the right buccal mucosa with extension into the right pterygoid plate and bilateral level 1, 1B and 2. Okay, lymph node involvement. So that says it is directly into stage 4 of your TNM staging. And apart from this, the other general findings which were there. So treatment plan was radiation therapy because it is beyond surgery. Okay, the whole area is involved. It is not practically possible to, open up and remove all that area surgically. So first you will try to limit the area or limit the spread of the lesion or size of the lesion after doing a radiation therapy, and then you will probably think of doing a surgery. Now this was after she underwent radiation therapy, and it is very sad for me to say that this particular patient, 31 years old, she had 3 children, and unfortunately she didn't survive for another 2 months. Okay, she passed away. She passed away even though she underwent treatment. It was not enough because it had spread beyond treatment. So just imagine a patient who just had a buccally erupted 1/8 and 4/8, and because of chronic cheek biting, she developed a full-blown carcinoma. And that carcinoma was not treatable, and eventually, she lost her life for it. Okay, so that is why something which can be as simple as a cheek biting or a chronic cheek biting habit, can it lead to carcinoma? That's what you all might think. Okay, yes. Chronic irritation over a period of time, superadded with other features like nutritional deficiencies or iron deficiency anemia, all this can lead to a full-blown carcinoma. Okay, so by all this, you all would have realized that the topic for today is oral cancer. Okay. Now, cancer by its very nature is an abnormal, seemingly unrestricted growth of body cells. Okay, and that is how we distinguish it from other forms of illness in our body. Worldwide, oral carcinoma is one of the most prevalent cancers, and one of the 10 most common causes of death is oral cancer. And your oral cavity and oropharynx account for approximately 3% of all cancers. Now, in males, oral cancer represent about 4% of total body cancers, whereas in females, it is 2%. And there are high rates reported in India and other Asian countries. Why? Because of our specific tobacco chewing habits. And the majority of oral cancers which we come across are squamous cell cancers. Coming to etiology, the cause of oral squamous cell carcinoma is multifactorial. You cannot pinpoint to one particular agent or factor. Okay? Though there are many carcinogens which are present, it is all more of a cumulative effect what happens. And both extrinsic and extrinsic factors play a role in initiation of cancer. Extrinsic factors include tobacco smoke, alcohol, syphilis, sunlight, and in this particular patient, there was chronic trauma. So that is also one of the extrinsic factors. Intrinsic factors include generalized malnutrition, iron deficiency anemia, hereditary, not even though for oral cancer, it is not all that a major role, but in general for cancer, hereditary plays a role. And if there's the presence of precancerous lesion, then there is definitely more chance of developing a oral cancer. Now, inflammation and cancer, this is what I was talking about in this particular case. It says that if there is a chronic inflammation, then yes, the patient is more likely to develop oral cancer. Okay. Now, this is one thing which you're supposed to know. That is pathway of oral tumorigenesis, or how oral cancer develops. Now, this chronic trauma or chronic irritation as such can be from anything. Irritation from your tobacco, irritation from your smoke, irritation from spicy food, or some kind of an ill-fitting denture or a buckly erupted tooth. Okay, your irritation or trauma can be in any of these forms. Okay, so what happens is there are two pathways which it takes. One is there will be presence of cellular death, and because of cellular death, your body tries to produce more cells. Okay, so there will be more cellular divisions. But these cellular divisions can be one which is produced with DNA damage. Okay. On the other side, you have chronic inflammation. And because of the presence of chronic inflammation, there is presence of chronic mediators of inflammation which is released. Okay, when your mediators, these kind of mediators are released, there is also formation of reactive oxygen species. Okay. So what happens is when all these cycles are in progress or in sight, because of the DNA damage and inhibition of the DNA repair, your first stage of cancer progression, okay, starts. That is initiation. So you have cellular death, you have more cellular divisions, which is of not the proper variant. Okay, the DNA which is produced, it's not correct. It is damaged DNA that is produced, and this is the DNA damaged DNA that is being produced is not being stopped also. Okay, so that is how your tumorigenesis starts. And next step is there is alteration of transcription factors. Again, this damaged DNA which is being produced is not being stopped. Why? Because there is alteration of your transcription factors. And again, because of this, something which has started is being promoted. And again, because of apoptosis inhibition and angiogenesis. Angiogenesis means new blood cells, new blood vessels. Okay. Now, apoptosis is programmed cell death. Okay, that is not happening here. If it would have happened, your damaged DNA, cells containing damaged DNA would have been apoptosed. That is not happening. So your cancer progresses. So when these two also starts happening, that is how you have the third stage or the stage of progression. Okay. Now, molecular changes in oral cancer, what you have to know is there is something called as oncogene activation and tumor suppressor gene inactivation. Okay. Oncogene means something which promotes your cancer generation. Okay. So you have genes in your body which promotes cancer. In our bodies, it is inactivated. Okay. Whereas in these individuals, your oncogene gets activated and tumor suppressor gene, okay, the gene which is supposed to suppress your tumor cells, gets inactivated. So the balance is lost. Okay. So your tumor suppressor gene gets inactivated, and therefore your cancer cells are being proliferated. Okay, so these genetic alterations include over-amplification of oncogenes, such as, just remember any of these names when you write about oncogenes. Okay, and tumor suppressor gene such as P16 and P53 are suppressed. Okay, these are your tumor suppressor genes. That is P16 and P53. Okay, so when the balance between these two are lost, that is how you have your cancer progression. Okay, so just remember the names of these. You don't have to know it in detail. So just remember there is something called as tumor suppressor genes and growth regulators. So in our head and neck region, what we are most commonly interested are something which is known as suppressor genes, which is called as P16 and P53. Okay, so these are the genes which we commonly see expressed in the head and neck region. And when you have a cancer or when you have some kind of a lesion, these genes are suppressed. Okay, so what are the presenting signs and symptoms when a patient has a cancer or some kind of a malignancy? Sometimes he or she might be totally asymptomatic, or they might present with a discomfort in the mouth, or mass in the neck, or growth in the mouth. They might complain of dysphagia, otalgia, trismus, oral bleeding, weight loss. Okay, all these happens in a later stage. Now, intraorally, when you examine, you can see a wide range of things. Okay, nothing is specific. So it can be a red, white, or a mixed lesion. There might be change in the surface texture. Some lesions can be smooth, some can be granular, rough, or crusted. There might either be presence of a growth or a mass, or it might be an ulceration. It can be either flat or elevated, minimally palpable, or indurated. There might be loss of function because of this particular growth or swelling. There might be loss of function of speech, swallowing, opening the mouth. Okay? And if there is fixation of the primary tumor to the adjacent tissues, then there is involvement of your periosteum also. Okay? So these are small examples of various type of malignancies which you can see. As you can see in the picture here, it is more of a ulceroproliferative growth. Okay, it is rough and you can see slight elevations and depressions, whereas here it is more or less like a smooth growth. And here again, it is an area of ulceration. Okay. Next thing which you have to know is spread of oral cancer. Okay, I'm sure most of you would have learned about spread of malignancies in your second year general pathology. Okay, the same applies here. The spread of oral cancer can be either by direct local extension, regional extension via lymphatics, extension through blood. Okay? So as you can see, a direct local extension can be through the spread in the oral mucosa by the or by submucosal spread, and changes in the basement membrane can bring about breakdown in your laminin and collagen, thereby helps in spreading more. And next is via your lymphatics. Now lymphatics, as you can see, the area on the same side is what is initially involved, but as the stages progress, lymphatics on the both the sides will be involved. Okay? And how you will be able to recognize these lymph nodes, they will be firm to hard in consistency, may or may not be tender, and fixation of the nodes is another sign of malignancy. That is due to the invasion of the cell through the capsule in the late stage, which signifies that that particular malignancy has reached an aggressive stage. Next important aspect in oral cancer is something called as diagnostic aids in oral cancer. Now this by itself can come either as a short essay or a short note. So it is very important to know all this. Okay. First thing is something called as vital tissue staining. Okay, vital tissue staining can be either using toluidine blue or blue Gall's iodine. Okay. Now, what is toluidine blue? I want everyone to listen carefully. Okay, toluidine blue, what happens is, now you have a cancerous tissue or you have some kind of a lesion which you suspect it to be cancerous. Okay. So what you do is, first you will clean the area, apply some acetic acid, and over that you will apply toluidine blue. Okay. After applying toluidine blue, you will wait for about say between 30 seconds to 1 minute, and you will rinse out the toluidine blue. And if the stain is present, okay, if you had some kind of a white patch, on that you apply toluidine blue. And after you make the patient rinse them out, you can see some areas of blue color still present. Okay, so that means that particular area is dysplastic. Okay, there are high chances of cancerous cells being present in that particular area. Why? Why? Because in your cancerous cells or in your dysplastic cells, as you have studied, you've studied about various features of dysplasia, right? Now, one of the feature of dysplasia is increase in your what? Nuclear cell ratio. So your DNA or nucleus is increased in your cancerous cells. So because there's more amount of DNA in your cancerous cells, these cancerous cells will take up your toluidine blue. Okay, so these cancer cells, they will take up the toluidine blue and it is not easily washed off. So that is how you will tell that this particular area is toluidine blue positive. Why? Because that particular area has dysplastic cells, and because dysplastic cells have more number of DNA because of the altered nuclear chromatin ratio, DNA is more in these particular cells. So it takes up the dye. Okay, so that is how your vital tissue staining works. Understood? That is toluidine blue, where it is the opposite for Lugol's iodine. Okay, imagine you had a white area or a white lesion, and you want to know if it is dysplastic or not. So you will apply Lugol's iodine. Okay, so the concept is opposite here rather than toluidine blue. What happens is your normal cells will take up your Lugol's iodine. Okay, Lugol's iodine will give a brownish stain. So if you have dysplastic cells or some kind of a cancerous tissue, your Lugol's iodine will not be taken up. Why? Because again the same concept. Your nuclear chromatin ratio is altered. Your cytoplasm is very, very less in your cancerous tissues. Okay? So it is in your cytoplasm that your gluconeogenesis or glycogenesis, all that takes place in your cytoplasm. So for your Lugol's iodine or the starch reaction to take place, you need glucose. Okay? So your cancerous cells have very, very little amount of glucose in it, whereas your normal cells have a lot of glucose. Okay, so that is why when you apply Lugol's iodine to your cancerous tissue does not take up the stain. Your normal tissue has lot of glucose, and that is why your normal tissue will take up your Lugol's iodine. So keep that concept in mind. Okay, what is vital tissue staining? It's a very common Viva question also. So your Lugol, what you're supposed to know is your toluidine blue and your Lugol's iodine. Toluidine blue is taken up by the dysplastic cells, whereas Lugol's iodine is taken up by your normal cells. Hope this is clear. If you have not understood, please ask me, I will repeat again. Okay. The other methods in which all these are chairside investigations. The other chairside investigation you can do is something called as Visselite and Wellscope. Okay, all these are basically difference in reflection of light. Okay, your normal tissues will reflect light in a particular manner, but your dysplastic cells will reflect light in a different manner. So all these you have specific instruments, and the way your normal tissue and cancerous tissue reflect the light is different. That is how you will differentiate if the particular lesion is dysplastic or not. Okay, then you have your fine needle aspiration cytology, sentinel lymph node scintigraphy, imaging, scalpel biopsy. Gold standard always is your scalpel biopsy. Now, coming to imaging in your oral cancer. Now, routine radiology, that is your two-dimensional radiology, what it will show is if there is presence of pore involvement, it will definitely be visible in your routine radiographs. And you can do ultrasonography for evaluation of your lymph nodes. And computer tomography is what we usually follow because that will give us both. It will give us the exact extent of your lesion. If there is presence of pore involvement, that can also be appreciated. And the lymph node assessment can be done with your CT scan. And in case if you have a soft tissue lesion or your soft tissue cancer, then magnetic resonance imaging is your imaging of choice. Then nuclear CT scanning can be done. That is evidence of bone involvement and bone necrosis following radiotherapy. And to know the spread or extent, or if there are any hot spots present in other parts of the body, you can do PET scan or PET CT, that is positron emission therapy along with computer tomography. You can combine both and it can be used. Details of the radiographic features, you all don't have to know all that in detail. You just have to know that the area can be widespread, which is involved. and periphery and shape of a carcinoma originating from the bone. It will have absence of encapsulation and uneven extensions of bone destruction. Okay, these are the features of malignancy or carcinoma which can arise from the bone. That its features are no features. Okay, it does not have a clear-cut feature. That is its main feature. Okay, as I said, CT is a little more what we prefer when we do the initial imaging because it gives us a better picture of the extent and the nodes involvement. Okay. Now this is important. Your TNM staging is very important. Most of the times it comes either as a short note or a short essay. So it is very important for you to know the TNM staging, okay? Because that is how it will dictate our treatment plan. If it is in a stage 1 or stage 2, you can go ahead and do surgical intervention. Whereas if it is stage 3, surgical intervention is not the first treatment of choice, okay? You will probably have to do radiation therapy or a chemotherapy depending upon your particular cancer. And then if the cancer has regressed, then you can probably think of doing a surgical intervention. Okay? So how you plan out your treatment, it's based upon this TNM staging. T signifies for tumor surface diameter, N signifies for absence or presence and extent of regional lymph node metastasis, and M is absence or presence of distant metastasis. All this you have to know. I'm not going to read out everything because this is something which you have to know. So kindly go back and read this properly, okay? So accordingly, you will have your different stages, and it's based on these stages that we do the treatment planning, okay? Now, histopathology, you have to know it to some extent because all of you have studied that in detail in your oral pathology. So just the basics is involved, that is the presence of dysplasia and the presence of keratin pearls if it is squamous cell carcinoma, okay, and your basement membrane will be violated in case of carcinoma. So the basic features, what is present, you all have to know, okay. Now coming to the treatment plan. Now treatment plan depends upon what type of cancer it is, okay. If it's a squamous cell carcinoma, your treatment plan is different. If it's anything else, it is different, okay. And the degree of differentiation also matters for our treatment plan. Site and size of a primary lesion, okay. Now, if you have a lesion which is situated in surgically accessible areas, then it is always advisable to cut and throw away that part, okay. So if you have a small lesion present at the base of a skull or posterior area of the oropharynx and all, it is difficult to surgically access these areas. So even if the lesion is small, that is less than 2 centimeters, surgical access is very, very difficult. So that also differentiates, okay? Even though it might be in a stage 1 or a stage 2, we might not be able to access that particular area through surgery, okay, because of proximity to vital structures, or if you end up doing a surgery, you might end up causing other comorbidities, that is, patient might end up having paralysis or anything else. Okay? So that is why we have to always see the site and size of the primary lesion before we jump into any kind of a treatment plan. Okay? And lymph node status is very important because if there is presence of widespread in lymph node involvement, then you might need other forms of treatment also. Presence or absence of bone involvement. Ability to achieve adequate surgical margins is very, very important because you don't want to do half a surgery and leave half your tumor there, because that's not going to serve the purpose. Presence and absence of metastasis, because if it is there, then you will probably have to think of other methods rather than surgery alone. Ability to preserve oropharyngeal function, that is including speech, swallowing, aesthetics, also medical and mental status of the patient. Okay. Now, surgery and radiation are used with curative intent. That is, you want to cure the patient of that particular lesion or cancer. It is with that intent that we do surgery and radiation. Now, chemotherapy is just an adjuvant therapy, that is, it is an added therapy. Along with surgery and radiation, you are going to add it. Okay, for oral cancers, chemotherapy is not a definitive first-line treatment of choice. Okay, whereas if you have other kind of cancers, like such as blood cancers and all, chemotherapy might be the first treatment of choice. But for most or 95% of your head and neck cancers, chemotherapy is just an adjuvant. Now, as I said before, T1 and T2 lesions, you can do surgery or radiation. Whereas if it's in the stage 3 or stage 4, then you need radiation and chemotherapy with or without surgery. Now, you do a radiation and chemotherapy and you observe or you